And we're now coming to the last winner of the Tito Bastianelli Awards. And this will be Dr. Vinchi from the New York Blood Center Iron Research Program in New York. Welcome, Dr. Vinchi. And Dr. Vinchi will talk on iron as a potential risk factor for atherosclerosis in elderly transfused MDS patients.
Is this a pointer? Yeah, okay, great. Good morning, everyone. So first of all, I would like to thank the organizer for giving me this award. Actually, it was quite unexpected, even because I'm a little bit an outsider in this community. I'm not really an MDS expert, rather an iron biologist by training. But I hope with this presentation to bring some attention to the iron overload topic and to show some detrimental effect that iron overload might have potentially also in transfusion-dependent MDS. And in particular, the focus would be how iron might induce and exacerbate cardiovascular disease. So you know much better than me that in the last year, a connection between cardiovascular disease and clonal hematopoiesis disease came up. This was mostly explained with the fact that clonal hematopoiesis might induce in the circulation a clone of mutant monocytes with increased pro-inflammatory function that eventually accumulate in the cardiac tissue and in arteries, and so predispose, accelerate eventually cardiac event and atherosclerosis. So I will be showing you in the next few slides how iron might increase atherosclerosis, also acting through a similar mechanism. This was basically the focus of our research. We tried to understand whether vascular iron deposition induces atherosclerosis, whether also iron by acting through the activation of monocytes and macrophages can further push the atherosclerosis in a similar way to what happened in upon CHIP. And the final question is whether iron overload might further aggravate CHIP-driven atherosclerosis. I don't have an answer yet to the last question. We are actively working on this, but I hope now to show you a little bit what is going on mechanistically in regard to the first two questions. So to analyze the impact of iron in atherosclerosis, we took advantage of a mouse model of genetic iron overload, which is all marked by elevated serum iron, elevated transferrin saturation, non-transferrin bound iron, and labile plasma iron, starting already at 3 months of age. And when we analyze atherosclerosis in this mouse model, we observe a much more severe phenotype in the iron-loaded mice, all marked by increased lesion area, increased lesion number, and all marked by particularly complex and advanced atherosclerotic plaque, which show a reduced collagen amount, increased lipid accumulation, and bigger and more frequent calcification that are all features that suggest that the plaque in these iron-loaded mice are particularly vulnerable and prone to rupture. In addition, when we go on and look a bit mechanistically what iron overload might induce in the cardiovascular system, what we observe is that basically non-transferrin bound iron induces endothelial dysfunction. The vascular endothelium in iron-loaded mice is particularly permeable, which might induce the infiltration of LDL into the subendothelial space, which is a key event in initiating atherosclerosis. The endothelium is also dysfunctional with reduced production of nitric oxide and is particularly activated with increased expression of adhesion molecules that might recruit more monocytes. But even more interesting was the observation really within the vessels of iron deposition. As I showed you before, transfusion trigger iron accumulation. This happened also in this genetic model of iron overload, and we noticed that basically iron strongly accumulates in the media layer of vascular smooth muscle cells, which is not observed in control mice. And whereas the media layer of vascular smooth muscle cell is iron-loaded, the plaque is almost completely depleted, which is very interesting. And we try to assess mechanistically why this happened. And what we saw is that basically vascular smooth muscle cells do not express ferroportin, so can accumulate, but they do not export iron. Whereas the plaque cells, they express ferroportin, so that's why they don't accumulate iron. This accumulation of iron is basically age-dependent, trigger damage and lipid peroxidation. And when we try to evaluate whether this aortic iron deposition matter for the severity of the disease, we nicely observe a direct correlation between aortic iron deposition and the extension of lesion area. The aortic iron deposition is, of course, a function of non-transferrin bound iron level, so it progresses when NTBI is clearly higher, and therefore, as a translation of this, the lesion area is also directly proportional to non-transferrin bound iron level in the circulation. So going a bit more into the mechanism, we took advantage of in vitro system, and what we have shown is that basically both endothelial and vascular smooth muscle cell, when exposed to a free form of iron that resemble non-transferrin bound iron, accumulate a lot of iron and produce reactive oxygen species, and this is totally prevented when in the medium is added transferrin or the chelator deferoxamine. Upon iron overload, endothelial and vascular smooth muscle cell undergo severe apoptosis, and the apoptosis is also observed in vivo. So when we go back to our mouse model of genetic iron overload, we observe apoptotic cells in the plaque as well as in the muscle layer of the vessel of our iron-loaded mice. And finally, what happened is that the apoptosis of iron-loaded vascular smooth muscle cell eventually trigger iron overload. What happens is that when we mimic an in vivo immune cell recruitment and we inject vascular smooth muscle cells that have been previously iron-loaded, what we observe is that these cells can induce the recruitment of huge amount of inflammatory cells, and this does not occur in mice that have injected with cells previously exposed to iron bound to transferrin or DFO. So basically only the non-transferrin bound iron by overloading the cells induce the recruitment of immune cells. And this reflects completely what happened in vivo in the mouse. Going back to the model of iron overload, we observe a massive recruitment of macrophages into the plaque of iron-loaded mice, but not of control mice. And these macrophages are responsible for the release of a number of inflammatory mediators within the vessel that contribute to atherosclerosis. Besides the increased recruitment of monocytes and macrophages that is induced by apoptotic iron-loaded vascular cell, we also have to consider that iron might have a direct action on monocyte and macrophage activation. We have, in fact, recently observed that when we inject simply free iron in mice, macrophages undergo an activation towards a pro-inflammatory direction, so they upregulate pro-inflammatory marker and inflammatory cytokines that are therefore released also in the circulation, and this effect is totally prevented by transferrin when iron is bound to transferrin. So this led us to a picture where inflammation and TBI-triggered inflammation seems to be relevant. So we asked the question whether we can use an anti-inflammatory phenotype and anti-inflammatory therapy to prevent the atherosclerosis that we observe in iron-loaded mice. And when we administered dexamethasone in mice, we observed a nice 60% prevention in atherosclerosis development. The iron parameters are unchanged as expected, but some vascular and inflammatory parameters are recovered in mice treated with anti-inflammatory phenotype. Anyway, the rescue is only 60%, so this suggests us that there is something more. Iron doesn't trigger only inflammatory effect, and acts also in different anti-inflammatory, non-inflammatory dependent mechanisms to induce atherosclerosis. And therefore, we asked if we really need to completely remove the iron from vessel to completely prevent the development of the disease. And the answer to this question is yes. When we give a low iron diet to mice, we basically observe a completely protective effect, meaning that iron acts both through pro-inflammatory and non-inflammatory mechanisms to induce atherosclerosis. We also applied a more clinically relevant approach to rescue the phenotype, and we administer mice a chelator And we observed that also the chelator, in this case the Ferrazirox, nicely protect from atherosclerosis and reduce the phenotype of the 65%. This rescue might not be complete because, as you can observe here, the reduction in aortic iron deposition is not complete. So we really need to remove the whole iron to prevent the effect. So just to summarize, what we have observed is that NTBI trigger a chain of events that leads to plaque formation, starting with the accumulation of iron in endothelial cell and vascular smooth muscle cells that eventually undergo apoptosis. And this trigger independent non-inflammatory effect, which induce eventually calcification, plaque destabilization, enlarging of the necrotic core, and therefore contribute to plaque formation. On the other side, endothelial cell and vascular smooth muscle cells might release inflammatory mediators, which trigger the recruitment of monocytes and macrophages that are eventually further activated by NTBI and induce the release of cytokines that trigger atherosclerosis. And just as last slide to give you some hints in regard to what happened in patients that are iron overloaded. Unfortunately, I don't have yet data on transfused MDS patients, but what we learn is that a cohort of transfused thalassemia patients show an upregulation, increase in NTBI level accompanied by an increase in the release and the expression of adhesion molecules and inflammatory mediator. And the same is observed in iron-loaded hemochromatotic patients. And what you can see in the last two groups of hemochromatotic patients that are phlebotomized patients, you can see a nice rescue upon iron depletion that occurs in all these parameters, meaning that really iron restriction strategies might nicely prevent iron-triggered vascular dysfunction and inflammation. And so this is the overall picture. I hope to have convinced you that iron might have a multifactorial action in atherosclerosis that could matter also eventually in transfused MDS patients and could act on top of clonal hematopoiesis, and that iron restriction strategies could be very useful to prevent this. And I would like to thank, of course, all the people that participated along the years to this project, and you for the attention.
Thank you very much for this excellent talk.